Good evening, good evening, good evening on Facebook Live and friends that have logged on. My name is Siobhan Arline Bradley, and I have the privilege of moderating one of the most esteemed panels in healthcare tonight. Tonight, you are joining us for At the Heart of the Matter, the effects of COVID and heart disease in vulnerable populations. On behalf of the Eastern Area HHS Facet, it is my honor to introduce to you, our listeners tonight, to the Eastern Area Director of the Lynx Incorporated, Dr. Shawana Tucker Sims. Shawana?
Thank you so much, Siobhan. To our 16th National President of the Lynx Incorporated, Dr. Glenda Newell Harris, Link members, and our guest, I bring you greetings on behalf of the officers, leadership team, and over 4,500 members in 80 chapters in the Eastern area. Throughout this month in the East and around the country, we have been joyously celebrating Black history in a number of ways. Tonight's program, aptly named At the Heart of the Matter, is about our future. We, individually and collectively, cannot do and be all we are meant to do and be tomorrow if we don't take care of our health today. We must be as dedicated to preserving our health and well being as we are to preserving our culture. We must be as committed to creating healthier lives and communities as we are about creating more educational and economic opportunity. Heart disease is killing us, and we must take a stand against it. The increased prevalence of coronary disease in communities of color proves challenging even in the best of times. Unfortunately, we know that the times in which we live are far from the best, as COVID 19 and its mutations continue circling the globe, and societies around the world scramble to vaccinate a sometimes wary public. The pandemic has highlighted heart health in vulnerable populations in two major ways. Heart disease is one of those underlying conditions that can lead to worse outcomes if an individual contracts COVID. And when someone contracts COVID, there is a potential for damage to heart health and lingering effects even after recovery. This devastating 1 2 punch is amplified among our most vulnerable populations. We have gathered a dynamic group of women to lead this important conversation. Dr. Glenda Newell Harris, Dr. Aletha Maybank, Dr. Dara Richardson Heron, and Dr. Angenette Ferris Sonatas. While they will all be officially introduced later in the program, I want to thank them now for lending their voices and insights this evening. I also want to thank Siobhan Arline Bradley, Eastern Area Health and Human Services Chair, and Dr. Jill Busey Harris, Eastern Area Co-Chair of Health and Human Services, for putting this program together and for the great work they're doing to keep health a priority in the Eastern Area. We have a great program ahead, and I would now like to present a woman who needs no introduction in LinkedIn, Dr. Marcella Maxwell, Eastern Area Platinum and Alumna Affairs Chair. Dr. Maxwell.
Thank you, and good evening, and welcome, Lynx sisters, to American Health Month as we spotlight our need to get to the heart of the matter. Notably, race related health inequities are affecting Black communities, in particular, as dual pandemics, COVID 19, institutional racism, and social unrest persist across the width and breadth of America and beyond. This evening, Sister Lynx, we will explore what impact these pandemics are having on vulnerable populations. There is a worrying picture. Regional data reveals that race and ethnicity of COVID 19 descendants indicate that Black patients are 3 times more likely to die at a much higher rate than their population share. Black Americans and Latino communities are the hardest hit by COVID 19 and Collectively, Black Americans make up 13% of the population, and they account for 25% of the deaths. Sister Lynx, Blacks are dying from the virus at roughly double their population share. With respect to self-care, self-care is our assignment. Daily, our heart works overtime. Our plates have become platters, and the now routine is a matter of the heart. Heart disease is the number one killer of women. Black women suffer from high blood pressure and diabetes disproportionately and run the risk of heart disease. Health and wellness is a 24/7 proposition. Lynx, please make health a habit. Eat a healthy diet of nutrient-rich foods, getting and staying active. Be determined, be disciplined, and be dedicated to exercise, exercise, exercise. Get your heart pumping, rest and renew, and reduce the rise of heart disease and stroke. Cardiologists, like one of our distinguished panelists, Angenette Ferris, are meeting us at viral hotspots, also known as hospitals. The fact is, we eat too much. Snacking has increased by 31%. We drink too much, increased alcohol consumption, and we exercise too little. And all of this is coupled with stress, depression, insulation, and isolation, as too many of us avoid physical checkups to check out what is really going on with our mental health, our physical health, and well-being. Lynx sisters, if your ticker stops, you stop. Tonight, the medical experts will give invaluable information, not only on the what, but the why, and yes, who must activate a strategic personal plan. When, when, now, to get to the heart of the matter.
Dr. Maxwell has given us our charge for the evening. The question is to our good doctors on the panel, can we follow that? She has given us some great tips, and we're going to jump into that tonight. A little bit of housekeeping for those that are online. If you are joining us on the Zoom webinar platform, we are over 300 online tonight, and we have even more joining us on Facebook Live. Please, 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 if you have a question, we want you to use the Q&A function. If you're on the webinar, use the Q&A function, and our team will help us track those questions. So tonight, it is my honor to introduce an esteemed panel tonight. I'll read brief bios, and we're going to jump right into our questions. We'll first start with Dr. Dara Richardson-Heron, a physician by trade and advocate by choice. She's passionate about leveraging skills and experience to reduce healthcare disparities. Dr. Dara is Pfizer's Chief Patient Officer, where she leads Pfizer's work to advance patient-focused programs and platforms. Now, before joining Pfizer, she served as the Chief Engagement Officer and Scientific Executive for the National Institutes of Health All of Us Research Program. Many of us are familiar with that program. And prior to that, she was a CEO at the YWCA USA. Dr. Richardson-Heron holds a doctorate in medicine from NYU School of Medicine and a bachelor's degree in biology from Barnard College, and is a member of the Lynx Incorporated. Dr. Dara, thank you so much for joining us tonight. Next, we have Dr. Aletha Maybank, a great friend and colleague who serves as the Chief Health Equity Officer and Group Vice President for the American Medical Association. She focuses on embedding health equity across all the work of the AMA and leads the Center for Health Equity. She joined in 2019 of April, launching that center as the inaugural Chief of Health Equity. And prior to that, Dr. Maybank served as the founding deputy commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene. Now, she has strengthened equity efforts across many organizations. She's taught medical school and public health students and is a sought after health expert in media on MSNBC, News One, and NPR. She has a BA from Johns Hopkins and an MD from Temple University and an MPH from Columbia University, Mailman School of Public Health. She's a pediatrician and preventive medicine and public health physician. Dr. Maybank, thank you for joining us tonight. I have the pleasure of also introducing Dr. Angenette Ferris Sonatas, who is a member of the Lynx Incorporated and a member of the Eastern Area HHS Facet. Now, she's a cardiologist and an assistant professor of medicine in the Division of Cardiology at the Patty Jim Calhoun Cardiology Center, University of Connecticut Health Center. She's the former director of the Lipid Clinic and past co-director of the Women's Heart Health Program at the Calhoun Cardiology Center. She's the author of Tracking Women's Awareness of Heart Disease, an American Heart Association national study. And she's led a number of articles as a member of Phi Beta Kappa Honor Society, the American Heart Association, and the Association of Black Cardiologists. Now, she earned her Master's of Public Health from Columbia. She completed her residency in internal medicine and fellowship at Columbia University Medical Center. She's a member of Alpha Kappa Alpha and the president of the Greater Hartford chapter of the Lynx. She is a busy, busy lady, but we are glad she's here tonight. Also want to mention she's a member of Jack and Jill because we have some Jack and Jill moms that have actually joined us tonight. Fellow mom, thank you so much for joining us. And last but not least, it is a pleasure for us to introduce the immediate past national president of the Lynx Incorporated, Dr. Glenda Newell Harris. Now, for those of us that are members of the Lynx, she is no stranger to us, but it is an honor not to only introduce her as our past president, but she is a physician. She specializes in internal medicine and is a media spokesperson. She served as a medical consultant in various healthcare settings, and for the past 6 years, serves as the regional medical director for Corazon Health Incorporated. The native of North Carolina, she received her biomedical degree from the University of Cincinnati School of Medicine and Bachelor of Science from Tufts, and also received numerous certifications in physician leadership. Now, she served 2 terms as our past president of the Lynx Incorporated, is a life member of Alpha Kappa Alpha, and currently serves on a number of boards. And to note, she has a number of distinguished honors from organizations like the NMA, as well as a National Medical Fellowship. Ladies, it is a pleasure to have you all on tonight. Now remember, these over 300 members that are online with us are going to be asking us questions in the Q&A chat. But we have our own questions that we want to start off with. So Dr. Maxwell, I'll get us started and then you can join with your question right after. So this first question goes to Dr. Glenda Newell Harris. Now, Dr. Glenda, your motto is take charge of your health. Now, could you describe briefly to us some of the best ways that our listeners can take charge of their health, considering we're in a pandemic and that we're talking about heart health tonight?
Thank you so much, Siobhan. It is an honor and a privilege for me to be here this evening. I want to bring warm greetings to my sisters in the Eastern area. And to get right to the heart of the matter, I just want to say that there is no time like the present to take charge of your health. What does that mean? That means that you cannot let this pandemic stop you from knowing your numbers. You cannot let this pandemic stop you from keeping your regularly scheduled doctor's appointments. You cannot let this pandemic stop you from advocating for yourself or your family. And you also cannot let this pandemic stop you from listening to your body. There have actually been some studies recently that have come out showing that during this pandemic time, we've had a decreased incidence of diagnosed about 6 different cancers, prostate, colon, and more. And the reason is because people are not keeping their doctor's appointments for whatever reason. They are afraid to go, or the doctor is, and let me just put a little pin in here and say, don't allow those video chats to take the place of the real doctor's appointment, because the video chats I've been a part of don't have peripherals to listen to your heart and lungs. So I say, know your numbers, get to the doctor, get those tests done, wear your mask, wash your hands, do all the things that you're supposed to do, but keep those appointments, keep knowing your numbers. And if you're like many of the rest of us, you've been in sweats and leggings for a year, you need to just recognize that you still got to know your numbers, and you need to slide into those other clothes periodically, because one day we're going to come out of them, one day. And you're going to have to be able, to put on something that's for real. So I say the same things that you were doing before, don't stop now. And you know what they are. Know your cholesterol, know your BMI, know your blood pressure, know your pulse. And before I end this segment, I'm going to say one more thing. Get the equipment that you need to be able to measure those things. Everybody under the sound of my voice should have a pulse oximeter, period, end. It used to be you needed a blood pressure monitor so you could know your blood pressure and your pulse. But everybody now needs a pulse oximeter, because that may be the thing that distinguishes you from deciding whether they're going to take you into the emergency room and admit you, or whether they send you home with antibiotics. I will
Glenda, that was amazing. Dr. Marcella, do you have a question?
Yes, for Dr. Dara Richardson Haran. Dr. Haran, how was the Pfizer team able to develop the vaccine so quickly?
Well, thank you so much, Dr. Maxwell. It's a pleasure to be a part of this esteemed panel. I just want to reiterate that although our team worked at unprecedented speed to develop the vaccine, safety was and will always be a fundamental priority. Essentially, with our vaccine, what we did was we got everything together from an access, a distribution, a supply perspective, so that we'd be able to move quickly if and when we received the authorization for the vaccine. So in addition to doing so many things in advance, we also made very intentional steps to do things in parallel. For example, as soon as we knew that we were going to develop a vaccine candidate, our teams began selecting sites for our clinical trial, and they staffed up our clinical teams in advance to make sure that we had the systems and the infrastructure in place to support and operate clinical trials all around the world. And additionally, once we obtained information that our vaccine candidate was potentially safe and effective at combating COVID-19, our teams actually took the risk to begin producing the vaccine in advance, even before it was authorized, so that we would have vaccine on hand for immediate distribution once it had received all the necessary approvals. And let me say this, sometimes in the usual drug development journey, the process of preparing all of the information and the data and submitting it to the FDA, it could often take weeks or months. But in the fight against COVID-19 across the globe, given the urgency, regulators responded to the information we submitted very quickly, often in real time, to help make sure that the trials were running as efficiently as possible. And, as it relates to safety, I need to really stress that we always maintain the highest ethical and scientific and clinical standards in all of our research. And for this study, as with all of our clinical trials, researchers were required to follow very strict rules and guidelines to make sure that participants were safe. For example, there's a clinical trial protocol, and it was independently reviewed by regulatory authorities, and it had to be approved by what we call institutional review boards. And those are people whose role is to ensure that human participants in research studies are safe. Our trial was monitored regularly by a group called a data monitoring committee, and they would have stopped the trial if they or we felt that there was a harm to participants. And so also there were planned follow-up visits where the study doctor monitored participants' health. And let me just say one last thing in this segment. Unlike many clinical trials in the United States, our COVID-19 clinical trial involved over 45,000 individuals from diverse racial and ethnic backgrounds. And that's really great news, because many of the studies that we see out there and many of the drugs that some of us are taking daily have never been tested in a significant number of racial and ethnic minorities. And so that's why I'm so pleased that our study was reflective of the population in the United States, and safety and efficacy were at the forefront.
Thank
you
you.
so
Yeah,
much.
that was very helpful. I'm going to shift a little bit. And these next two questions, one's for Dr. Ferris, and then I'm going to sneak over to Dr. Maybank and then turn over to Dr. Maxwell. So, Dr. Ferris, you are a cardiologist. So this conversation tonight is around COVID and heart disease and really the effects on vulnerable populations. So my question for you first is, heart disease is the number one killer of all women. So this includes Black women. I want to be very, very clear on this, that we're talking about Black women specifically. Our question is, why do we struggle in this area of heart disease? And then your second part of your question is to tell our listeners tonight, how would they know they're having heart attack symptoms or other symptoms?
Here, Siobhan, I thank you so much. I thank Dr. Tucker Sims and Dr. Maxwell for inviting me to be on this esteemed panel tonight and to talk about what's near and dear to my heart, heart disease. As you rightfully mentioned, heart disease is the number one killer of women in the United States and of men. And unfortunately, since 2019, heart disease has surpassed all other forms of illness throughout the globe. So now, not only in the United States, but heart disease is the number one killer globally. So sadly, other countries have caught up. And in the past, there were countries, infectious diseases was the leading cause of death. So now heart disease is a worldwide issue, and we're kind of fighting several pandemics at the same time. And specifically for Black women, we definitely have to focus in on our health. And it's important that we're having this discussion in February, Heart Month. So women over the age of 20, specifically Black women over the age of 20, 58% of us have some form of heart disease. And that number is staggering. Compared to white women, about 42% of white women over the age of 20 have heart disease. So we are disproportionately represented in this disease form, and we want to try to reduce our risk. And the question is, why is there such a preponderance of heart diseases in our community? Multifactorial, but one of the leading issues is that we have multiple risk factors for heart disease, and they're prevalent in our community, such as high blood pressure, diabetes, elevated cholesterol level. Thankfully, many of us are not smoking. We know the detrimental health both on the heart and lungs for smoking, but of course, smoking is a risk factor for heart disease. So there are many risk factors that we carry, and it's important if we do already have these risk factors. For example, we can do everything. We can try to kind of modify our lifestyle to bring down our blood pressure. But if that doesn't work, we have to work with our healthcare provider to bring down our blood pressure. Because even if we're already diagnosed with hypertension or diabetes, the important thing is to have those under control. So as Dr. Glenda Newell Harris mentioned, knowing your numbers is key. Know your blood pressure. You want your blood pressure to be 120/80 or lower. That's what we're trying to target. You want to know what a lot of times you go visit your healthcare provider, they check a fasting glucose level. That gives us a sense of if there is any evidence of diabetes, or there may be a hemoglobin A1C. That's another number that we measure to see if there is diabetes. So we want to really be on top of it, know our numbers. We want to know what our cholesterol numbers are. And we want to go into that office with a pen and paper so we can write down our numbers and we can compare it to our numbers the following year. So you want to keep track, and you want to be an ally and an advocate for yourself, and you want to work in conjunction with your healthcare provider. So those are kind of the important issues that we need to focus on, reducing our risk by modifying our risk factors as best we can. And a lot of it comes from what Dr. Maxwell mentioned, eating a healthy diet, exercise. And I always say exercise is the best medicine. So if we try with lifestyle modification initially, we can make significant strides in reducing our risk, but we have a lot of work to do still.
And just, I don't want to miss this opportunity.
Yes.
Signs and symptoms of heart attack.
Absolutely key. And that's important. And I'm going to go through them, but it's important even now, because now in the age of COVID, we are staying away from the hospital. And understandably, we want to try not to expose ourselves. But if you're having symptoms that are new, you want to make sure that you're seen, because a minute, 2 minutes, 5 minutes can be the difference between life and death. So signs and symptoms of a heart attack, classic symptom is chest pain or pain in the center of our chest. But women, we can present differently. So a lot of times we may present with just shortness of breath. So we're able to walk up 2 flights of stairs, no problem. That we find that we're struggling now to just go up those same 2 flights. That's a difference. And that's something we want to pay attention to. And a lot of times we're always taking care of everyone else and not focusing in on ourselves. So listen to your body. So chest pain, it can be shortness of breath. It can sometimes be jaw pain because we have nerve endings. And a lot of times that pain may radiate just to the jaw. We may not feel any pressure or pain in the center of the chest. And when we say pain in the chest, oftentimes it feels like a heaviness or pressure. That's one sign. And you want to immediately, if you're experiencing that at home, you want to immediately call 911. Don't try to drive yourself to the hospital, because we can get to you, and we can ensure that you get the medications on board quickly, because the essence is time. It's really critical. So chest pain, shortness of breath, jaw discomfort. Some people will have discomfort in their arms or heaviness in the arms, left arm or right arm, just perspiration, a little nausea. So all of them can kind of present kind of very differently. And oftentimes women may present differently. And oftentimes women over a certain age, a lot of times we lose some of our nerve endings, and we may not feel that pressure in the chest, and we may just be perspiring or short of breath. So anything that you notice that's different, you want to ensure that you call 911. It's better to be safe than sorry. And also, if you're starting to have a little bit of difference, then you want to ensure that you're in communication with your doctor, but don't stay away. As Dr. Newell Harris, don't stay away. The video conference is good, and we are able to see a lot of patients that way, but a lot of times we need to listen to that heart. We need to get that EKG done. And it's important to come in if you're having symptoms.
So friends, we have over 350 participants. They're already sending questions, but I have a very specific question for Dr. Maybank. You are the Chief Health Equity Officer. And for many people that don't know, equity in our language is a little bit different than equity may be in the public, right? So when we do public health work, health equity is something that's really important to us, especially as Lynx, as we think about our communities. So our question for you is, why is, first, defining health equity for us, why it's important, and then talk to us about what the AMA has been doing to address inequities in general, because what our listeners will find out, it's all connected to these issues that all the doctors have been talking about tonight.
Yes, absolutely. And thanks, Siobhan. I just want to thank you for the invitation to the panel always, and for your friendship, but also for the topic of the panel. I think so many times the way these conversations happen, they happen in isolation. So like we have heart disease in this other body and COVID in this other body, and not like together. So to really integrate this conversation, I think is absolutely critical. And it's really an honor to be on this in this discussion with everyone. And Dr. Maxwell, I remember you from when I was at the Suffolk County Department of Health, at my first role as starting the Office of Minority Health there. And you were an advocate and partner then. So it's really awesome to see you still in this leadership space. So health equity, overall is really ensuring that all of us, every one of us, has the conditions, the resources, the opportunities, and the power to achieve optimal health. And the reality is that we know in our experiences as being Black and Brown people, and women as well, that hasn't happened, for us in its totality. And so a lot of the work that I do is working to ensure that health equity, working with systems and hospitals and doctors' offices now in the AMA setting, to make sure that they're working to embed and center equity. And so when I say that, what I'm meaning is that one, and this is Dr. Kamara Jones's framework, I have to give her credit for this, is one, valuing all individuals and people equally. So, right, we're all born equal. We may not be treated equal, but we are all born equal. And it's imperative that our systems do treat us equitably. And that's different than even equal, because the reality and part of her frame is providing resources according to need. And because so many aspects of our community have been not treated fairly, and there is kind of disinvestment, there are more needs oftentimes that are needed for our community, another important part of our frame. And the other important part of the frame is really understanding the historical context. We didn't just get here. So when we talk about heart disease and high blood pressure, I think it's absolutely important we talk about, what do we have power over? What can we control? And I think there's an important aspect of it, but from my lens, it's important that I'm holding the systems and the institutions that have set up these unequal conditions for us over time, holding them accountable to doing better and to changing and looking at what they're doing to dismantle racism within their systems, so that we have the conditions so that we can do what we want to do, what we have a right to do, and have a right to health in this country. So at the American Medical Association, specifically to heart disease, in one, just elevating that frame, because I think it's just an important frame. And our other friend, Dr. Joya Carrere Perry, always says, right, it's racism, that's the risk factor, and not race. And that's what we really have to make sure we focus on and keep the lens on, or else we're going to be blamed. It's almost like we're blamed for having this heart disease, and that's just not fair or the case. But what we are working with, like the healthcare institutions, and it's on a program we call MAP. So it's already been actually mentioned already. Measuring accurately is like the first step of hypertension control. So we're doing a lot around high blood pressure. The second part is making sure institutions and doctors, when they see high blood pressure readings, that they act rapidly with whether it's treatment or medication. And then 3, it's like partnering with patients and families and communities to make sure there's self-monitoring and management. So I just want to go a little bit deeper in what each one of those means, because otherwise I don't think it's fully useful. So when I say measuring accurately, what we did in some of our studies that we found that even I, as a trained healthcare professional, oftentimes we're not really trained in detail. How do you take accurate blood pressure readings? You kind of watch and you learn and you do. But what we found in many studies that blood pressure is not even being taken accurately in the healthcare provider setting. So things like when you cross your legs, so your legs should be uncrossed and sitting down. And I think this is important for our advocacy. So if somebody doesn't do this for you, you point it out. But you can have a reading off by 2 to 8 millimeters. If the cuff is over your clothing or the cuff is too small, it's not supposed to be like that. If you have a full bladder, evidence shows that can cause higher blood pressure reading. If you're talking, or like how I'm talking now, or actively listening, that can elevate your pressure. If you have an unsupported arm, and really you're not supposed to be on an exam table, you're supposed to be in a chair, again, with your feet down. But if you notice even for yourself, where you go and when you go to the doctors, how they're taking blood pressure is really important. It's an important part of accountability. Already was mentioned in terms of knowing your numbers. So I won't go through those, but that was absolutely critical. Those have changed. And I think, I hear our community say this, well, it's only a little over 20 over 80, but no, we need to 120 over 80 rather. We need to adhere to that. Like 120 over 80 and anything higher than that is actually an elevated blood pressure. And right. you and your healthcare provider should be responding to that. And so we at the AMA, in terms of partnering, we just launched an initiative called Release the Pressure. In this last year, we initially launched it with Essence, as well as with the American Heart Association, the National Medical Association, the Association of Black Cardiologists, and the Minority Health Institute. And what this really is a pledge for all of us, and we operate in our squads, right? In our friends group, and we understand that. So it's a culturally relevant, program. And so it's about, setting a blood pressure goal with your healthcare professional. We really want that relationship to be there, whether it's a provider, whether it's a physician or a nurse practitioner, whomever it is. The second part is monitoring your blood pressure numbers. So it was already mentioned just a second ago about the importance of having self-monitoring blood pressure cuffs at home for yourself or for whomever. The third part is like activating a personal wellness plan for your fitness and eating. And then the third is like checking in regularly with your squad to help you with these goals. And so if you go to releasethepressure.org, you can find out more information. We just had an amazing event this past weekend. Again, a partnership with Essence and Angela Lee, Girl Trek. And it was a national vision board party. It was like our inaugural party, but that's really to kind of galvanize us and to build momentum and to bring some joy into this
Absolutely.
really difficult time of COVID, and that we can still be joyful and still be healthy all at the same time.
We are getting at the heart of the matter tonight. So I'm going to turn it over to Dr. Maxwell, who has our next question.
Yes, I wanted to continue with Dr. Maybanks. Does the AMA, Dr. Maybanks, have a proposal to present to President Biden that addresses the health inequities among communities of color in the country and how to mandate recommended changes?
Yes, so we don't have a formal proposal, but we work very closely with the Biden administration as we worked with other administrations. But I think there's going to be a unique opportunity for this administration because they've already put out very strong signals that equity is a priority. We have already executive orders focused on racial equity that's supposed to happen throughout. We have, the reversal of some transgender bans from before that are now reversed. And I think all of these are just signs and signals that this administration is going towards a really strong direction of not only naming racism and racial injustice, but holding themselves accountable to it. And so in my recommendations in terms of for the administration and what we'll be speaking with the administration about are, one, making sure that they do have systems and structures in place that are more anti-racist. And I think one of the key ways to do that is really considering what we call, this is kind of new to folks, is it's like a health in all policies approach and an equity in all policies approach. So it's not just like healthcare and the healthcare and delivery of healthcare, and as you go to the hospitals and doctors that need equity and justice, it's all of our systems that need equity and considerations of health impact. So whether it's education or transportation or housing, we need to have a better coordination of these systems and thinking about how all of these come together to impact health and also can advance equity. And so that's one of the big kind of recommendations and considerations for this new administration. Of course, universal health care is absolutely key and critical to making sure that we are all healthy. I think also ensuring that health is considered a human right. We really have not embraced that fully in this country, and I think that goes along with the aspects of universal health care. And there are many other things that are related to our workforce and making sure it's more diverse and making more there's just access and more funding for that is absolutely critical. And how we, we're talking a lot about this and actually speaking to administration now. This is collecting race and ethnicity data at minimum. And what are the systems and structure and what's the money for us to be able to do that? Race and ethnicity data, absolutely critical to help us take care of our health and our community's health. It's an equity strategy.
Thank you. Dr. Perron, I would like to ask you, segments of the minority community have demonstrated a reluctance to get the well-established annual flu shot, which in many cases have resulted in mortality. There is a reluctance with respect to the COVID vaccination, in part because of the rapid FDA approval and historical mistrust of the government. So the question is, does Pfizer have a plan to develop an annual one-dose COVID shot? And if so, what efforts will be made to educate, motivate, and engage the minority community?
Well, thank you, Dr. Maxwell. Again, that's a really loaded question. Let me just start with the reluctance. You're absolutely right. Vaccine hesitancy didn't just start with the COVID vaccine. An estimated 45% of American adults received the flu shot in the 2018-2019 season, but that number is even smaller when you look at adults of color, where an estimated 39% of African Americans and 37% of Hispanic Americans received the flu vaccine. So again, vaccine hesitancy did not start with the COVID vaccination, but I think it's important, as Dr. Maybach mentioned, that we put some contextualizing around the mistrust or reluctance, because many communities of color have a well-earned mistrust in our nation's healthcare system, due in part to historic transgressions where people of color were not treated with respect, and in some cases were even harmed. I mean, think about the Tuskegee syphilis study, the unauthorized use of Henrietta Lacks cancer cells, the Guatemala syphilis experience, the Havasupai tribe experience. The list goes on, unfortunately, but we don't even have to speak just in historical terms. Many communities of color still today face barriers to accessing high quality healthcare services, irrespective of socioeconomic status. And, we talked about it just a few moments ago, institutional and systemic racism, implicit bias, microaggressions. I don't even know why we say microaggressions, because most of them are actually macroaggressions. But the truth of the matter is, taken together, these egregious acts have left a long-lasting legacy of trust and willingness of people to participate. And the thing that I want to say is, to your point about reluctance for the COVID vaccine, There was a study from the Kaiser Family Foundation that talked about public's attitudes and experiences with the vaccine, and it was taken around the middle of December, and it said that while 27% of the general public said that they probably would not get a vaccine of COVID, about 35% of Black adults said that they probably or definitely would not get a vaccine, and again, that compares to about 26% of Hispanic, the Hispanic population. And then you said in your opening remarks that there were discrepancies, but there was a Kaiser Health News analysis of state health department data that reported vaccine recipients' race and ethnicity, and it showed that Black vaccination rates were 3 to 5 times lower than white vaccination rate. Let me say that again. Black vaccination rates are 3 to 5 times lower than white vaccination rates. Now, this is a problem because those who are perhaps at greatest risk of dying from COVID-19 are among the least likely to get a vaccine. And, that's a real problem. And we've got to do a lot to undo the mistrust that we see because, we're seeing around 3,000 Americans die each day as a result of COVID. That's roughly 2 deaths per minute. And then there was a study done by the APM Research Lab's Color of Coronavirus project that showed that about 1 in 735 Black Americans has died from COVID-19 as compared to about 1,030 white Americans, 1 in 1,030. Let me say that again. About 1 in every 735 Black Americans has died from COVID, while 1 in 1,030 white Americans has. And Indigenous Americans are the hardest hit group with about 1 in 595 dead. And for Pacific Islanders and Latinos, the rate is about 1 in 1,000. And all of these numbers I'm giving you may actually understate the gaps. But we have so many barriers that we have to overcome. To your point of whether or not we plan to have a 1-dose vaccine, we don't have that in the cards right now. We're hoping that people will get the 2-dose vaccine, which we know to be safe and effective, and we really want people to get that. Certainly along the lines, we'll maybe do something different, but we really just want people to go out and get the vaccine. And in terms of your point about educating communities, we have been out there, every day pretty much talking to communities, working with them, hearing from them, and really understanding their needs. And we will continue to do that. One of the things that we really have to do is to dispel many of the myths that are out there. Despite the many memes and other information on social media that say otherwise, we have to make it clear that there's no microchip in the vaccine, right? We have to make it clear that you cannot get the virus from taking the vaccine. Given the world we live in, many people seek out Dr. Google for their health information, but it's really important for us to stress that it is so vital for people to talk to trusted and respectable and reputable resources for their health information, because we're dying every day. So we've got to really make sure we get the right information. We have to have the right messengers out there with the right message at the right time. So I hope I touched on all of your questions, because that was loaded.
But Dr. Maxwell gave us a loaded question. I got to follow up with this though, because I think this will be for Dr. Dara and Dr. Glenda. Okay, it's gonna be a 2-parter. All right. So Dr. Dara, you set us up because you answered 2 questions that were already coming through. Like, is this vaccine safe? But there's another question that continues to come up, which is the second vaccine and symptoms that comes with it. So a lot of conversation has happened publicly about second vaccine. So the question is, should I take a Motrin or a Tylenol before I get my second shot? And if I continue to have symptoms, is it okay to continue taking Tylenol? That's your question, Dr. Dara. Then I'm going to sneak over to Dr. Glenda, because we started to tap into this question about Black communities and negative thoughts. We want to hear about your response to the Black community, what you would advise the Black community in terms of taking the shot. And then we're going to throw this out on the table for anyone to answer, but there's these strains that keep coming up. So we want to make sure we tap into this, okay? So Dr. Dara, we're going to start with you. The second vaccine, right? what should we do if we get the second vaccine? Should we take Motrin? What should we do?
Yeah, that's a good question. And, I always, I have to preface everything by saying, people should really talk to their own doctors about,
Absolutely.
making decisions. But let me just be clear. The reality is, those medications that you're talking about, like Tylenol or Motrin, they can be taken after, you've gotten the vaccine and you have the symptoms, the chills, the aches. But it's not really recommended that you take these medications before you go in and get the vaccine to prevent them from happening. As uncomfortable as they are, it's your body's way of saying, hey, this vaccine is working. So I would just, tough it out, before, but after, if you're feeling like muscle aches and pain and fatigue, take, Tylenol. When you think about our study, the study that we did with about 46,000 people, we didn't tell them don't take Motrin, don't take Tylenol, and we were able to determine that the vaccine was effective. So again, talk to your own doctor, but if you're talking to me, what you're going to hear from me is that take them, but take them after, you've had the vaccine. Don't take them before.
And Dr. Darrell hit those strains that keep coming out, UK strains. So, we keep hearing all this stuff. What do we do? Do we still get the vaccine even in response? And then Dr. Glenda, you got to talk to the people and tell us how you would advise them. So Dr. Darrell, then we turn over to Dr. Glenda.
Yes, there are so many strains out there. I mean, it's like when you hear it every day, it's just frightening. And let me just be candid. I'm speaking now as Dara, not as, Pfizer. I'm saying I understand and hear, and understand the fear and the concern. Yes, you should still take the vaccines that are out there. They've all been found to have effectiveness in the new strains. Certainly our teams and other teams are taking a look at this new strains and trying to figure out a way to make sure that you're protected. But as for now, the vaccines that are out there are what's available. And I certainly recommend that you take the vaccines.
Dr. Glenda?
Great, thank you. So I'm just going to say to our audience, I'm going to address about 7 kind of dispelling myths, and then I'm going to charge you with some things that I think you need to do. So number 1, the vaccine was studied in more than 45,000 people. So you've heard that from my panelists here. So as has been pointed out, I am confident that there are some of you that are taking medications right now that were not studied in 45,000 people. So that's the first thing you do need to understand. And unless you read these studies, this is our area. Engineering's not my area. I love engineers, but you have to respect the people that are in this field. So 45,000 people that submit themselves for a study, that's a lot of people. Number 2, we were in that study. Now, often these studies are in Omaha, Nebraska, and, other places like that where we're not, but 10% of the people in the studies looked like us. So we can no longer use that as an excuse. Number 3, this virus does not do well in people that have comorbidities. What are comorbidities? Well, if you have high blood pressure, if you have diabetes, if you have heart disease, now I'm going to go into the deep water. If you are a little overweight, I'm going to go to the obese side, okay? We're not talking about overweight. We all have those challenges. But they are also saying that people that are in the obese category are not doing well with COVID-19. And regrettably, every time I go to the NMA, we as people of color are at the top of all those lists. We got the highest hypertension, the highest diabetes, the highest heart disease. So if you have any of those comorbidities, now, of course, you must speak with your doctor first to get approval, but you don't want to be caught with COVID-19 if you have those other conditions. Number 4, this is not a live virus. You can't get COVID-19 from this virus. And I'm going to also put in, we had a sister involved in the making of this vaccine. Now, folks, just remember, we had a sister at the helm. Our sister Kizzy has been studying this for a long time. So let's don't discount that. The next thing, no studies have shown that it has made anybody infertile. That's the next line. Will this vaccine make me sterile? There are no studies that has somehow taken on a life of its own, and people are believing that. So the answer to that is no. Now, if you have any parents or elderly friends, if you love them and want to hug them ever in life again, you need to think about sacrificing yourself if you consider a vaccine a sacrifice. And consider taking this vaccine so that you will be able to go and visit your mother. My mother, as you all know, because my sister and I are too public about it, is 103. And she had her first vaccine about 3 weeks ago. And we are prayerfully hoping she'll make it through the next one. But the point being is I've had to stay away because I want my mother to live until I am fully vaccinated. And a little peep into my life, I got the second vaccine yesterday. So let me tell you, those chills are real, folks, but medicine is good. So my arm hasn't fallen off yet. The 181 million doses that have gone out. You've heard nobody's arms have fallen off. Our Lynx sister, Kamala Harris, her arm didn't fall off. She's gotten the vaccine. Biden's arm didn't fall off. So, there are just a lot of myths out here. So now my charge to you, this is what I want you to do. Leaders lead. So if you consider yourself a leader, then I say you go out and tell other people that you have taken this vaccine. I couldn't get on this panel unless I had, and I'm doing another one on Saturday, and I'm doing that one with the faith-based community. And that moves into another arena. So you've got your target of groups of people that love you and think you're wonderful and fabulous, and that's who you need to talk to. And some people listen to their pastors. So I reached out to my pastor. We're doing a faith-based community because many people, they don't trust their doctors, but they trust their pastors. And so leaders lead. You've got to get out there. You've got to take that vaccine. You've got to tell people your arms didn't fall off and that you took a little Motrin or a little Tylenol afterwards if you needed it, and you got on with your life. So I say that to the Black community because the alternative is we will then be faced with going up there to the front of the emergency room, and somebody put in the chat, what are the benefits of the pulse oximeter? Well, the pulse oximeter tells you how well you're getting oxygen around. And often that's the deciding factor as to whether they say, come on in and we'll admit you, or go home and take this doxycycline for 10 days and come back, if you're not feeling better. That pulse oximeter lets you know how well you're getting oxygen around. And those numbers mean something to doctors and health professionals. So you can get one now while things are going well, find out what your pulse ox is when things are fine. But sometimes there are very subtle symptoms of shortness of breath that you don't pick up, but the pulse oximeter will pick it up.
Hey, Dr. Maxwell.
Yes, I have a question for, I think it's Dara. Note that you served as the CEO for NIH All of Us program, a research program that involved precision medicine that seeks to provide health care focused on each person as an individual. Could you share a bit about the program and what you experienced with engaging minority patients to participate in a research program?
To do so, Dr. Maxwell. Yes, prior to joining Pfizer, I was the Chief Engagement Officer for what you may know as President Obama's initiative called the All of Us Research Program. He announced it in his State of the Union address in 2015. And the goal really of that initiative was to engage 1 million or more individuals to increase diversity in biomedical research and build one of the world's most diverse and valuable patient databases to help researchers better understand and address health disparities, and very importantly, ensure that future medical advances benefit people from all backgrounds. As we've all been saying, now, we're not participating in research in the numbers that we should be. And I always say, if you're left out of the research, you may be left out of the cure. So that's why I'm so excited that we were able to have minority participants, racial and ethnic minorities, in our COVID study, because it's actually been tested on them. As Dr. Newell said, 10% of our study participants were African American. That way we know how the vaccine impacts various different communities. And what we really want at the end of the day is to make sure that the medications that are developed, the treatments that are developed, whether it be a vaccine, whether it be a surgery, whether it be a medication, whatever it is, if we're not involved, we may not benefit. So that's why it's so very important for us to be involved. Very proud to be a part of that program. And then I brought that experience to my work here at Pfizer. And so really, really proud to be a part of that program. And it's going well. It's really going well.
Thank you so much. We're going to shift to Dr. Angenette because there is this conversation around COVID and heart disease. And then the chat is going crazy. I know we're almost at the top of the hour. We're going to try to give us about 5 extra minutes to make sure we grab a couple of the questions. This is for you, Dr. Angenette. You are in-house cardiologist. And so there's a joint question that came in. If I contract COVID, will I have heart issues after being diagnosed? And there's a second part to this. And if I have a young person, a child that may be an athlete, that's in sports, maybe on the basketball team or on the soccer team, and they contract COVID, right? Because we know we have some young people that have also contracted the virus. Should parents have concerns about those young people returning to work out or practice? We all saw the young gentleman who actually passed out live on television after a basketball game, who we knew contracted COVID, young African-American student athlete. So if you contracted, will you have heart challenges? And then if you have a child that has contracted the virus that plays sports, should we be concerned? And then we'll open up the floor for a couple of questions before we end.
Excellent question. So there is a very definite strong correlation between heart disease and COVID going both ways. So if you already have heart disease, if you have coronary disease, blockages of the arteries of the heart, or if you have abnormal rhythms of the heart, what we call arrhythmias, you are at higher risk. As Dr. Newell Harris mentioned, a lot of risk comes along with kind of putting us at higher risk from developing poor outcomes with COVID. So, individuals with hypertension, have a 6% higher case fatality rate than those at baseline. With diabetes, 7.3% higher case fatality rate. So these are important. And so if you have underlying heart disease, you're at a higher risk of having poor outcomes with COVID. And so that's why you want to be extremely cautious. If you yourself have it or if a family member has it, you want to protect them as well. But it goes the other way. So if you develop COVID, even if you're young and healthy and you develop COVID, 20 to 30% of individuals who develop, who have COVID may develop some cardiac side effects. So a lot of times with developing COVID, our body tries to fight the virus off. And so we get kind of an inflammation that oftentimes can become system-wide, go throughout our body. And so that inflammation can then kind of target the heart. And so what we call that is myocarditis, or an inflammation of the heart. So you can be completely healthy and you may develop some heart manifestations with COVID. So it's important, even if you're diagnosed and even if you're feeling well, to just ensure that you follow up with your healthcare provider. And if you've been very symptomatic or had a very bad case, you want to ensure that you follow up with studies to ensure that the heart muscle recovers if it has been affected. Good question about athletes. And so there are guidelines now for athletes. For example, if an athlete is asymptomatic, doesn't have any symptoms with COVID, of course, they have to take that 10 to 14 day recovery period and be isolated. But if they've been asymptomatic, and of course, always follow up with your healthcare provider and make sure you have that discussion. Usually they don't recommend further testing, but if a young person in their 20s or teens does develop COVID and has kind of what we call moderate to severe symptoms, they are recommending further follow-up, kind of cardiac follow-up and risk stratification in order to evaluate the heart, especially in athletes. And so kind of really they are, they work their hearts really hard when they're, playing their sport. And so we want to make sure that that heart is healthy and they haven't developed a myocarditis, that inflammation of the heart. And we want to ensure that, there's no unfortunate event that occurs when they go back to sports. So there's gradations and stratification. So definitely if there's a young person, and I always say, even if you're young and healthy, it can affect many organ systems, specifically the heart. And so you want to ensure always follow up with your healthcare provider, irrespective, even if you are asymptomatic, and if you definitely have an athlete who's a child and they've developed some symptoms, or even if they haven't, that's a question you want to pose to their pediatrician or to your healthcare provider. So excellent questions.
Thank you.
So we are at the top of the hour, and I know we need to open this up for audience questions. So what we'll do, Dr. Maxwell, I have a list of questions that are coming in from the audience that is live. So to the audience, if you can hang in there with us for a few more minutes, we want to at least try to get to a couple of questions. We are still at over 350 people live on this webinar, and still we have folks in the hundreds live on Facebook. So we are tapping into a lot of listeners. So I'm going to try to combine some of the questions. And this first question is for Dr. Maybank, and I'm going to do it's a two-parter to cover a couple of the questions. So I know Dr. Darris talked about microaggressions being macro, which was amazing. The question is, we know that systemic racism, microaggressions contribute to high blood pressure, and we can't control that. So one, what are your thoughts about that? How racism is a part of the stress, and then how do we hold systems accountable? These are two questions that came in together from our audience.
There we go. I'll mute myself. Thanks for the questions. So it talked. I want to go back to what I talked about what we have control of in our space and what we don't have control of, and it's different for each of us depending on what your work role is. Like, I'm hired to kind of fight systems, fight white supremacy, and fight racism. So that is in some level of my control, but it is, I recognize, very stressful at the same time. I totally agree. It's racism, and that's what it is. I don't like to use the terms microaggressions, and sometimes not even bias at that, and really get to what the root causes are. And so I have tools that I'm able to use, at work to help do that. And I recognize not everybody has that. And I think that is fine and okay. I think there's more information out there to equip ourselves with the language. There are the books on how to be an anti-racism, because I don't make the assumption that we as Black people, I know we've experienced racism, every single one of us, but to understand how to communicate around it in a way that talks about systems and what does it mean to be a racist versus anti-racist. I think we need to build up that language more often so that we can actually have productive conversations with our families and at work as well. And that's something that we do have in control. So just how we talk about it and build that shared analysis, I think is helpful for our health overall. And then I go back to, the root of this conversation and focusing on those things that we can control about, going for our COVID testing, go for our COVID vaccines, our blood pressure control, all the things that all the doctors have mentioned on here that are in our control. Those are the things that we need to continue doing in our lives. And in terms of just holding systems accountable, when you go to your doctor's office, so earlier, I think all of you have been equipped with information in this call in very powerful ways that you are now able to say to your doctors or to your healthcare providers or to your systems, no, this is what I heard and this is what I know. I've learned this from a trusted group of people, and this is what they told me. And so that is advocacy right there. That is power, and that's holding a system accountable to what you know. And that's an important part of, I think this work. I think also holding accountable is what I mentioned before. Like when you get your blood pressure, you now know how to get your blood pressure and what they should be doing. Those things matter. And oftentimes we don't have that education, and most of us didn't go to med school or health professional school to know it fully. But when we know something is not right, then we have the opportunity to do better and to hold people accountable that way. I think oftentimes we do feel sometimes challenged to speaking up to our healthcare professionals for many different reasons. And it can be intimidating, the environment, or, just for many different reasons. But the point is that y'all have power, y'all have the point of your voice, and to advocate for what it is that that's right. You know your body, you know how you feel, and now you know more information. And so again, I recommend, I'll just refer again to the Release the Pressure website, because on it, not only are we talking about heart disease, but we do have information about blood pressure and COVID as well. We wanted to make sure we had videos and all of that accessible to people.
Great, this is great. So each of you are going to get this closing question. So this next question is for Dr. Dara. It's a combination question. We see some of our Lynx sisters that are online already. So this is a joint question. If you don't have side effects, does that mean the vaccine isn't working? And are there any pre-existing conditions that would keep someone from getting the vaccine?
Yes. So let me start with the first one. If you don't have side effects, that does not mean the vaccine is not working. Okay. So no, it doesn't. Our bodies respond differently to the vaccine, but certainly do not for one moment feel that if you don't have side effects, that it's not working. What the studies have shown is that you tend to have more side effects after the second dose. But if you don't, that does not mean that the vaccine is not working. And then the second question was around, remind me.
Pre-existing conditions.
Pre-existing
Would that keep
conditions.
someone from getting the vaccine?
Yeah, so if you have had a severe allergic reaction to vaccines, you really should talk to your doctor first before you get this one, right? And then I will also direct you to the CDC website. There's a list of conditions there that
Yes.
really, you need to think about, before you get the vaccine. But as with everything, you have to talk to your doctor and make the best decision. But the one thing for sure is if you've had a serious what we call anaphylactic reaction, where you've actually stopped breathing after taking a vaccine, there are recommendations that you should strongly consider not getting the vaccine at this time. But I urge you to go to the CDC website. There'll be plenty of information there.
Great. That was from our Lynx sister, Lynx Vashti McKenzie. We see you on the line. So big hugs to you. Thanks for sending those questions in. Thank you so much. Now, this is for Dr. Angenette. There's a connection between heart health and oral health. Can you talk about the role oral health plays in having heart disease, right? What message could you share for the need for good oral health? And then we'll close out with Glenda.
What studies have shown us is that there is definitely a correlation between the health, our oral health and health throughout our body. And specifically, if we focus in on the heart, a lot of studies are still underway, but what we found is that the inflammation, oftentimes if we don't address oral health or diseases of the gums, we develop inflammation, and that inflammation oftentimes can then manifest in other parts of our body. So we're still trying to figure out what the direct link is. And there's also been kind of studies on particular types of bacteria and that's affecting the heart in certain ways. But definitely it's important to keep a healthy mouth and ensuring that you follow up with your dentist or oral health care provider, because again, that inflammation is kind of a culprit throughout our body, and it can affect our gums. It also can affect our hearts. So really keeping a healthy mouth will also help us to keep a healthy heart as well. And also there's, particular heart disease, endocarditis, which is kind of an inflammation or an infection of the valves of the heart. And so we want to really just ensure that our oral health is kind of intact so that we avoid seeding any bacteria to other parts of our body, specifically the heart. So a lot of studies are still in the works, but there definitely is a correlation. And we find that individuals with poor oral health have elevated risk of also having a heart disease. So those studies are still being done, but we definitely know there is an association.
Great. And Dr. Glenda, this last question is for you, then I'm going to turn it over to Dr. Maxwell to close us out. Dr. Glenda, there's a couple questions actually running around blood pressure and sustaining your medication maintenance. So one, the questions are really centered around, if my numbers are improving, should I be continuing on my blood pressure medication? One, and then does white coat syndrome really affect your blood pressure? Very interesting questions.
Yeah, great question, Siobhan. So thank you for those. So let me take the first one. I'm going to say to you that unless your blood pressure is dropping precipitously, then if you have been prescribed blood pressure medicine, it's good because you're taking it. It's so funny. When I was in private practice, I used to say to patients, oh, your blood pressure is great. And then they come back the next 3 months and they were off of their medicine. I'm like, what happened? Well, you said my blood pressure was great. Well, it was great because you were taking the medicine. So we need to be very clear in our communication as doctors. But if you are taking blood pressure medication and your blood pressure is running 100 systolic or 90, then I think it's time for you to have that conversation with your doctor about maybe I'm on too much blood pressure medication. But if your blood pressure on medication is running where they have told you 120/80 and in that family, you should keep taking your medication. Only if it's dropping precipitously, and it should be associated with lightheadedness and feeling like you're going to faint and things like that. If that's not happening, then stay on your medicine. The other question about white coat syndrome. I'm going to say yes. I believe in white coat syndrome. If you've ever, as a doctor, and I have, if you've ever, as a doctor, been a patient, it's scary on the other side of that table. It's scary when somebody has information about you. And as a doctor, we always think the worst. So I've been there with my family, and fortunately, I've tried to practice what I preach. I'm out here running around in Oakland in the rain, trying to get my walking in. But yes, when you come into the doctor's office, your doctor should allow you to sit and relax for a minute. And if you have fear about other information they're going to give you, if you're supposed to get your biopsy report back, well, that's probably not the day that they adjust your blood pressure medicine based on what information that's coming back to you. So yes, stress is real, and stress will kill you, my sisters. I promise you, stress will kill you if you allow it. So my closing comments to you are, this is all a heart of the matter. I love you all. It's all about the heart, and you need to look at yourselves and take care of yourselves first. Because if you don't focus this health on your body, you won't be there for the husband, the grandchildren, or anybody else, your Lynx sisters, your grandparents, your job, and they will, they'll forget about you in 5 seconds. So I say to you, just focus, listen to your body. If you don't feel right, take your blood sugar, because you have that unit at home. Take your blood pressure, check your pulse. And with heart disease, we didn't even get off into atrial fibrillation, which is a whole nother conversation that impacts us as we get older. But just focus on yourself, because if you are able to focus on yourself, then you're going to be able to be an advocate for all of the friends and family that are going to need your support.
And Dr. Glenda, there's a question about your faith presentation. Is it available to the public?
Absolutely, it is available to the public. I don't know the best way. I have a flyer. I've posted it on my Facebook page, but if the sister will, you can copy my email down.
Yes, you can.
At Yahoo, and I'll send you the flyer that has the Zoom link on it. We'd love for you to join.
And I think Madam Area Director, we'll go ahead and post that as well. Dr. Maxwell, can you close us out with your words, and then we'll turn it over and bid everyone what a night. All I can say is what a night. Dr. Maxwell?
Yes, our checkup this evening, Sister Lynx, is our alert for preventive health care. Now we know better, and it is on us to do better. We have been enriched by the Heart to Heart with our distinguished and distinct panelists, whom we celebrate for their wise counsel. We know for certain that the adage is correct. No one escapes life alive. Again, let me say, if your ticker stops, you stop. Therefore, we commit to work while it is day, to be and become, and rest be ourselves. And that is the heart of the matter. Thank you.
What else can we say? We got to the heart of the matter, and Dr. Maxwell closed us out. Madam Area Director, any closing remarks before we bid everyone a great night?
I just want to say thank you to this outstanding and amazing panel for sharing your information, just the wealth of your knowledge, sharing it with our members and our guests that have joined us this evening. It has been invaluable. The text, the chat, I mean, our sisters and our guests are commenting how informative and how educational this has been for them. So I thank you. And to all of our guests and our sisters that joined this evening, thank you for taking the time to listen and learn. We appreciate all of you, and thank you. May everyone stay safe and remain well.
Awesome. Madam Area Director, thank you for your leadership and your vision. Yes, this was recorded. I see all your questions. Yes, it was on Facebook Live. I understand there's a lot of family members watching this together, husbands and wives and children. To all the amazing doctors, this Black woman magic is ecstatic tonight. You are amazing. Dr. Dara, Dr. Angenette, Dr. Aletha, Dr. Glenda, we honor you tonight. Dr. Maxwell, it was my privilege to serve as your co-captain tonight. And we will bid you all a great evening.
Yes.
Good night, everyone.
Good night.
Good night.
Good night.
Good night.